Chronic pancreatitis presents a complex and evolving challenge for both patients and clinicians. While often associated with lifestyle factors, this condition manifests through a unique constellation of symptoms and complications, many of which require a nuanced understanding beyond conventional medical wisdom. Recent insights shed light on its multifaceted nature, guiding more effective management strategies. A common misconception is that chronic pancreatitis always follows an acute attack. However, a significant number of patients, between 30 and 65%, never experience a documented prior episode of acute pancreatitis. This highlights the insidious nature of the disease. Despite this, alcohol and smoking remain the dominant risk factors, driving over 50% of cases. They act as independent contributors, but also exhibit a synergistic, dose-dependent effect. The underlying mechanism involves recurrent or continuous injury to the acinar cells, which then activates pancreatic stellate cells, ultimately leading to damaging fibrosis within the pancreas. One of the most pervasive and progressive complications is pancreatic exocrine insufficiency, or EPI. This occurs due to the loss of acinar cells, or blockages in the pancreatic ducts, severely impairing digestion and leading to malabsorption. Patients often experience steatorrhea, which is fatty stools, along with bloating, unexplained weight loss, and deficiencies in vital fat-soluble vitamins. Diagnosing EPI is critical and often begins with a fecal elastase 1 level. A value less than 200 strongly suggests the condition. Regular annual screening with this test, coupled with a thorough review of symptoms, is recommended for all patients with chronic pancreatitis. The cornerstone of management for EPI is aggressive pancreatic enzyme replacement therapy. A typical starting dose involves 40,000 to 50,000 units of lipase taken with meals, and half that amount with snacks. If symptoms persist, the dose may need to be doubled or even tripled. To enhance enzyme efficacy, a proton pump inhibitor, or PPI, can be added to the regimen, helping to prevent the enzymes from being degraded by stomach acid. Beyond digestive issues, chronic pancreatitis also frequently leads to endocrine insufficiency, manifesting as type 3C diabetes. This form of diabetes is particularly challenging, often described as brittle, because all cell types within the islets of Langerhans are damaged. This results in a dual deficit of both insulin and glucagon, leading to significant glycemic lability and a high risk of dangerously low blood sugar or hypoglycemia. While insulin is frequently required, metformin can also be an efficacious treatment option. However, certain diabetes medications are generally not recommended. SGLT2 inhibitors are usually avoided, as are sulfonylureas, due to their high risk of hypoglycemia in patients who lack adequate glucagon counterregulation. GLP-1 inhibitors are also typically sidestepped, due to a potential, though debated, risk of exacerbating pancreatitis. The pain associated with chronic pancreatitis evolves significantly over time. In the early stages, pain might be linked to ductal hypertension and obstruction, often referred to as the plumbing theory. This suggests that blockages cause pressure and discomfort.
However, as the disease progresses, the pain becomes multifactorial and increasingly driven by neuropathic processes, dubbed the wiring theory. This involves peripheral sensitization, where there is inflammation and hypertrophy of the pancreatic nerves, and central sensitization, where altered pain processing occurs in the central nervous system. This central sensitization can cause pain to persist even in the absence of ongoing inflammation, which explains why surgical drainage procedures, even if technically successful, often fail to resolve the pain completely. Historically, there was a burnout theory, suggesting pain would diminish as the gland fibrosed, but long-term data has largely disproven this, showing that 84 to 90% of patients continue to experience pain. Given the neuropathic origins, managing this pain requires a multimodal approach that incorporates non-opioid medications and adjuvant therapies like gabapentin or pregabalin. Interestingly, the ESCAPE trial suggests that early surgery, performed within 3 years of diagnosis, may offer better long-term pain relief and be more cost-effective than an endoscopy-first approach for some patients. Chronic pancreatitis significantly elevates the risk of osteoporosis. The exocrine insufficiency leads to reduced absorption of fat-soluble vitamins, particularly vitamin D, and essential minerals like calcium. This bone health issue affects nearly 2/3 of patients with chronic pancreatitis, putting them at a 2 to 4-fold increased risk of fractures. Therefore, it is crucial for patients to undergo a DEXA scan at the time of diagnosis and have it repeated every 2 years to monitor bone density. Patients with chronic pancreatitis also face a substantially elevated risk of pancreatic cancer. This condition is considered one of the strongest risk factors for developing pancreatic adenocarcinoma, increasing a patient's lifetime risk 7-fold above the general population. However, because the absolute risk remains relatively low, routine surveillance imaging is generally not recommended for all patients.
patients. An important exception is for those with hereditary pancreatitis caused by the PRRSS1 gene mutation, where the cancer risk can be up to 60-fold higher, making surveillance a recommended course of action. For some individuals experiencing severe intractable pain, total pancreatectomy with islet autotransplantation is an option. While this procedure can be effective for pain management, it's important to understand its limitations. Insulin independence is often not durable, with only about 30% of patients remaining insulin-free post-procedure, and this rate tends to drop over time. Moreover, the procedure carries a high risk of permanent iatrogenic diabetes, meaning diabetes caused by the medical intervention itself. Understanding the unique characteristics of chronic pancreatitis, from its varied presentation to its complex pain mechanisms and metabolic complications, is vital for providing comprehensive and effective care. This deep dive into the latest insights emphasizes a holistic, patient-centered approach to manage this challenging condition.